It is in medicine cabinets across the country right now, in a little blue and white box, on the nightstand next to a glass of water, sometimes in a basket by the bathroom sink. You have probably taken it yourself, maybe dozens of times. Maybe you take it every single night. It does not require a prescription. It is sold in every pharmacy, every supermarket, every corner drugstore. It is marketed as safe. It is marketed as effective. And it is taken by tens of millions of people over 60 who have never once been told by anyone what it is doing to their brain. Not because their doctors are negligent, because most doctors genuinely do not discuss it. It falls outside the standard conversation. It sits in a blind spot that the medical system has not properly addressed, and it has been quietly causing measurable, documented cognitive damage in older adults for decades. My name is Jade. This channel exists for one reason: to bring the information that lives in research papers and specialist journals into plain language into your home before it matters. Because too often, people only find out about these things after the damage has been building for years. Today I am going to show you what this medication is, why it affects your brain so profoundly after 60, what the research actually shows about long-term use, and exactly what you can do about it. No alarm, no panic, just the information you deserve to have. Stay with me. The medication I am talking about is not a single drug. It is a class of drugs, and the name of that class is something most people have never heard: anticholinergics. That is a long and unfamiliar word, but the mechanism behind it is something I can explain in 60 seconds in a way that will make complete sense. Your brain runs on chemical messengers called neurotransmitters. Different neurotransmitters handle different functions. The one responsible for memory, learning, and attention, the one that allows you to form new memories and retrieve old ones, is called acetylcholine. Anticholinergic drugs work by blocking acetylcholine. They prevent it from binding to its receptors in the brain. That is literally what the name means. Anti, meaning against, cholinergic, meaning related to acetylcholine. Now here is why this matters enormously after 60. Your brain naturally produces less acetylcholine as you age. The system is already running with reduced capacity. When you add a drug that actively blocks what remains, you are suppressing the very neurotransmitter your memory depends on in a brain that can least afford to lose it. And here is the part that stops people cold when they hear it. This class of drug includes some of the most commonly taken over-the-counter medications in America. Benadryl, diphenhydramine, which is the active ingredient in most over-the-counter sleep aids, including ZzzQuil, Unisom sleep tabs, Tylenol PM, and dozens more. Most first-generation antihistamines used for allergies, some common anti-nausea medications, some bladder control drugs, some older antidepressants. These are not obscure pharmaceuticals. They are household names, and tens of millions of older adults take them regularly, many every single night, with no idea that they carry this particular risk. I want to go a layer deeper on the biology, because understanding why this is specifically dangerous after 60 and not just at any age is what makes this information genuinely actionable rather than just alarming. Think of your brain's acetylcholine system like a reservoir. When you are young, that reservoir is full. Your brain produces plenty. If a drug temporarily reduces the level, blocks some of the receptors, the system has enough reserve to compensate. The effect is temporary and manageable. You feel a little foggy, maybe a little slow. The next day, it is cleared. But after 60, the reservoir is lower. Not because something has gone wrong, because this is a natural part of how the brain changes with age. You produce less acetylcholine. The system has less redundancy, less capacity to absorb disruption. Now take a drug that actively blocks the remaining acetylcholine every night. Not occasionally, every night, week after week, month after month. The reservoir cannot recover between doses. The system is perpetually suppressed. And here is what that looks like from the outside. And this is the part I most want you to hear carefully, because this is where the real danger lies. The symptoms of anticholinergic drug effects do not feel like a drug reaction. They feel like aging. Difficulty concentrating, forgetting words mid-sentence, walking into a room and having no idea why, feeling mentally slower than you used to, a slight but persistent fog that is just always there. These are also the earliest symptoms of cognitive decline, which means millions of people are experiencing drug-induced cognitive suppression and attributing it to getting older. They are not worrying about a medication side effect. They are grieving what they think is their mind beginning to go. That is not a small thing. That is an enormous, largely invisible public health problem. Let me give you the studies. Not as a vague reference to research suggests, but the specific findings in plain language that have been published in major medical journals and that every person taking these medications deserves to know about. The JAMA Internal Medicine Study, 2015. This was one of the most significant findings in recent pharmacology for older adults. Researchers at the University of Washington followed over 3,400 adults aged 65 and older for an average of 7 years. They tracked cumulative anticholinergic drug use over time and monitored who developed dementia. The result was stark. People who had taken anticholinergic drugs for a total of 3 or more years showed a 54% higher risk of developing dementia compared to those who had not. 54%. Not a marginal increase. Published in one of the most respected medical journals in the world. Now pause here for a moment. Do you know someone over 65 who has taken a sleep aid or an antihistamine most nights for several years? Someone who just keeps the same bottle on the nightstand and takes it without giving it much thought? Because that is exactly the pattern this study was measuring. The University of Nottingham study, 2019. British researchers analyzed the medical records of nearly 60,000 patients over 65 with dementia, matched against over 225,000 controls without dementia. They found a clear, significant association between anticholinergic drug use and dementia risk, particularly for drugs taken over long periods. The association was strongest for bladder drugs, antidepressants, and, significantly, antihistamines. Including over-the-counter antihistamines, the ones people buy without a prescription and take without a second thought. What struck researchers about this study was not just the finding, it was the dose-response relationship. The longer the exposure and the higher the cumulative dose, the stronger the association. This is not correlation noise. This is a pattern with a biological mechanism behind it. The bidirectional trap. Here is the finding that I think deserves the most attention and gets the least. Anticholinergic drugs are often prescribed or taken specifically because of symptoms that themselves may be early signs of cognitive decline. Poor sleep, anxiety, bladder urgency. These can all be early manifestations of neurological changes. So a person experiencing early cognitive decline takes a drug to manage one of its symptoms. That drug then suppresses acetylcholine, accelerating the very decline that produced the symptom in the first place. The medication prescribed to help is quietly making the underlying problem worse. That cycle, once recognized, changes everything about how we should think about these drugs in older patients. This is the most practical section of this video, because knowing the mechanism and the research matters, but what you actually need is to be able to look at a medication label and know whether you are holding something in this class. I'm going to walk you through the 4 categories where anticholinergic drugs are most commonly found for people over 60. For each one, I will tell you the warning signs that this specific drug may already be affecting your cognition. Category 1. Over-the-counter sleep aids. This is the biggest one in terms of sheer numbers. If you have ever taken NyQuil, ZQuil, Unisom sleep tabs, Tylenol PM, Advil PM, Benadryl, or any generic nighttime or PM formula, look at the active ingredient. If you see diphenhydramine, that is an anticholinergic. It is the same compound in all of them. It is also one of the most potent anticholinergics available over the counter. The warning sign that this is affecting your cognition is specific, and different from simply feeling groggy the next morning. It is this: you feel mentally slower and less sharp not just the morning after, but consistently through the following day. A fog that does not fully lift by noon. That is not normal drowsiness. That is acetylcholine suppression that is lasting longer than the drug's intended window. Category 2. Antihistamines for allergies. First-generation antihistamines, chlorpheniramine, brompheniramine, promethazine, are strongly anticholinergic. These are found in older allergy formulas and some cold medications. The critical distinction here is that second-generation antihistamines, loratadine, Claritin, cetirizine, Zyrtec, fexofenadine, Allegra, are not anticholinergic or are significantly less so. They cross the blood-brain barrier far less effectively. If you take daily antihistamines for allergies, this distinction matters enormously. The warning sign here is word-finding difficulty, that frustrating moment where the word you want is simply not there, hovering just out of reach. Occasional word-finding lapses are normal. Frequent ones, occurring consistently during periods of antihistamine use, are worth noting. Category 3. Bladder control medications. Drugs prescribed for overactive bladder, oxybutynin, tolterodine, solifenacin, are among the most potently anticholinergic medications in common use. They work by blocking acetylcholine receptors in the bladder. The problem is, they also block acetylcholine receptors in the brain because they cross the blood-brain barrier readily. Oxybutynin, in particular, has one of the highest anticholinergic ratings of any commonly prescribed medication. This is one of the most painful ironies in geriatric medicine. Bladder urgency and frequency are themselves sometimes early signs of cognitive and neurological change. The medication prescribed to treat them may be worsening the underlying neurological picture. The warning sign is a pattern of confusion that seems to have worsened since starting the medication, or that fluctuates in intensity. If your thinking feels noticeably clearer on days when a dose is missed, that is information worth taking to your doctor. Category 4. Older antidepressants and sleep medications. Tricyclic antidepressants, amitriptyline, nortriptyline, doxepin, are sometimes prescribed for sleep, for chronic pain, or for depression in older adults. They are strongly anticholinergic. Benzodiazepines, such as diazepam and lorazepam, while not anticholinergic by mechanism, also suppress cognitive function through a different pathway and are associated with dementia risk in long-term use. The warning sign here is a general cognitive dulling that feels different from normal tiredness, a sense that your thinking has become less precise, less quick, less reliable, that correlates with when you started the medication. Now the part that matters most. Because everything I have just described is only valuable if it gives you somewhere to go. Information without action is just anxiety. So here is exactly what to do. First, let me tell you about someone. I will call him Raymond. He was 73 years old, a retired engineer, the kind of man who had always been precise and detail-oriented. He had been taking a sleep aid, diphenhydramine, every night for 6 years. He had mentioned to his doctor that his thinking felt slower. He had been told it was normal for his age. He had started to believe it. His daughter found the research on anticholinergics and brought it to a specialist appointment. The specialist reviewed his full medication list. The sleep aid was the first thing flagged. Over 8 weeks, with medical supervision, he was transitioned off it onto a low-dose melatonin protocol. Within 3 months, Raymond described something he had not felt in years. He said the fog had lifted. Not completely, not overnight, but meaningfully and unmistakably. He had assumed it was aging. It was a drug he had taken every night for 6 years because the box said it was safe. That story is not rare. It is common. What is rare is someone catching it. Here is the protocol. 4 specific steps. Step 1. Audit your medicine cabinet today. Go through every medication, prescription, and over-the-counter that you take regularly. For each one, write down the active ingredient. Then search that ingredient alongside the word anticholinergic, or look it up on the Anticholinergic Cognitive Burden Scale, which is freely available online and rates medications from 0 to 3 based on their anticholinergic potency. Any drug rated 2 or 3 deserves a conversation with your doctor. Step 2. Ask the right question at your next appointment. Not, is this medication safe? That question almost always receives a reassuring answer. Instead, ask this specifically. Given my age, can we review my medication list for cumulative anticholinergic burden? That phrase, cumulative anticholinergic burden, signals to your doctor that you have done your research and that you want a specific, informed answer. It changes the quality of the conversation immediately. If your doctor is unfamiliar with the concept, that itself is information worth having. Ask for a referral to a geriatric pharmacist, a specialist whose entire focus is medication safety in older adults and who will know this literature thoroughly. Step 3. Never stop or reduce a prescribed medication without medical guidance. This is not optional advice. It is critical. Some of the drugs in this class, particularly benzodiazepines and certain antidepressants, have serious withdrawal effects if stopped abruptly. The goal is a supervised, gradual transition under medical care, not a unilateral decision made after watching a video. What you can do immediately, without medical guidance, is stop the over-the-counter sleep aids. Diphenhydramine is not a medication you need medical supervision to discontinue. If you have been taking it nightly, stopping will likely disrupt your sleep temporarily as your body readjusts. That disruption is real and worth knowing about in advance, but it is not dangerous and it passes. Step 4. Know the alternatives. For sleep, the evidence-based alternatives that do not carry anticholinergic risk include low-dose melatonin between 0.5 and 1 milligram taken 90 minutes before bed, not the 10 milligram doses commonly sold. Research suggests lower doses are more physiologically appropriate. Magnesium glycinate, 300 to 400 milligrams at bedtime, has solid evidence for improving sleep quality. Cognitive behavioral therapy for insomnia, CBTI, is the single most evidence-supported treatment for chronic insomnia and produces lasting results without any pharmacological risk. For allergies, the switch is straightforward from first-generation to second-generation antihistamines, loratadine or cetirizine. Same symptomatic relief, dramatically lower cognitive risk. Ask your pharmacist today. It requires no prescription and no doctor's appointment. For bladder medications, newer options exist. Mirabegron, for example, works through a different mechanism and has a much lower anticholinergic profile. This specific conversation requires your prescribing doctor, but it is a conversation that is absolutely worth having. I want to step back for a moment before we close, because there is something important that sits behind all of this that I think deserves to be said directly. The research on anticholinergic drugs and dementia risk has been in the medical literature for decades. The JAMA study I mentioned was published in 2015. The Nottingham study in 2019. These are not new findings sitting in obscure journals. They are published, peer-reviewed, replicated findings in mainstream medical publications. And yet, the box of diphenhydramine on the shelf at your pharmacy says nothing about cognitive risk. The pharmacist who hands it to you with your prescription is unlikely to mention it unprompted. The doctor who has been prescribing an anticholinergic bladder medication for years may never have had this specific conversation with you. This is not a conspiracy. It is a system that moves slowly, that has enormous inertia, and that was designed primarily for acute care rather than long-term cognitive protection. The information exists. The translation of that information into the everyday lives of the people it affects has simply not caught up. That is the gap this channel exists to close. You now know that anticholinergic drugs block the neurotransmitter your memory depends on. You know that after 60, that system has less reserve to absorb the impact. You know that long-term use is associated with a 54% higher risk of dementia. You know which drug categories to check. You know what questions to ask. And you know that for at least some of these medications, better alternatives exist. That knowledge, specific, actionable, evidenced, is not something most people walk into their doctor's office with. You now do. The most important thing I want you to leave this video knowing is not a drug name or a study citation. It is this: a medication being available without a prescription does not mean it is without risk for your specific body at your specific age. The safe label on a box was written for a general population that includes 25-year-olds. It was not written for a 68-year-old brain with naturally reduced acetylcholine levels taking that drug every night for 4 years. You are not that general population. You are you. And you deserve information calibrated to who you actually are, not who the average consumer of that product happens to be. If this video gave you something useful, and I hope it did, please share it. Think right now of someone in your life who keeps a sleep aid on their nightstand. Someone who has been taking an allergy pill every day for years. Someone who has mentioned that their thinking does not feel as sharp as it used to and assumed it was just age. Send this to them. That one action might matter more than you know. Take care of that brain. It is the only one you have, and it is far more capable of protecting itself than most people realize when it has the information and the conditions it needs to do so. One final thing, and this is important. Everything in this video is based on published peer-reviewed research and is for informational and educational purposes only. It is not medical advice. Please do not stop or reduce any prescription medication without first speaking to your doctor. Some medications require supervised tapering and should never be stopped abruptly. Bring this information to your next appointment. Ask the specific questions I described. Your doctor is your partner in this. And that conversation, informed, specific, and unhurried, is exactly where good medicine begins.